Hi, I am Dr. Campbell Norris, and welcome to the Red Chair.
Palliative care, it's a specialty and it's a discipline, but it's also a movement. And it's going to take time. And it's going to take for our more well-established providers, right, out there in the world, it's really a philosophy change.
It will be a challenge, and I think just kind of reminding myself why I'm here and to help the clinical team understand the difficulties that this patient is facing and their families facing, because they are not just a room number or a medical record number. This is a whole life.
Now, today on the Red Chair, we have Dr. Chowdhury and Katelyn. Welcome to both of you.
Thank you.
It's such an honor to have you here. You are doing great things out there, and I just want everybody to know. So, Dr. Chowdhury, oh my goodness, you are a palliative care physician. Tell me about that.
So I think my passion for palliative kind of came when I was a resident, and I was a second-year internal medicine resident. And I just noticed that, we have our heart doctors, our lung doctors, our GI doctors, our psychiatrists, but there was really never no people doctor. And so I look at palliative medicine as being the person doctor, looking at things as a unit, and realizing that we only judge our patients who we see in the hospital just in those four corners. These people have lives and stories and so much more outside of being in healthcare, which really affects their well-being, their livelihood, their decisions, but we never really talk about them. And so a part of what palliative does is really takes a person's values and wishes and puts them in the forefront. And so I'm a very strong advocate and believer that in order for a person to be well and cure and have a good quality of life, we need to make informed decisions, and they need to have everything, pieced together to make that decision in order to continue living and fulfilling their mission in life. And so I kind of took it upon myself to continue with the palliative medicine fellowship after residency, and really focus on what my patients wish, what the families wish, and how we can give them that meaningful quality of life while they're living with chronic terminal medical conditions. And so that's where I found my calling.
Awesome. Thank you. And you know that palliative care is just really next to my heart. And for viewers out there who really don't understand what palliative means, could you explain that for
Sure. So palliative medicine is a subspecialty of medicine that focuses on a patient's values and wishes, and it is geared towards patients who have chronic life-limiting terminal conditions. So we do a lot of symptom management, things like pain, shortness of breath, anxiety, nausea, vomiting, what have you, that can affect a person's overall well-being. At the same time, we also talk about the future. We're often planning for the next degree or the next social event or the next holiday, but nobody really plans for what is to come when things get rough. And so a lot of what I do is really sit down with patients and talk about their goals and values and wishes when plan A does not work, and what plan B looks like. And in the event that they get really sick, how do they want to live their last days, if you will? Because as my friend Katie always says, that endings matter, and there's this journey, and it all depends on how each person wants their journey to be, because the ending is still the same.
And those people have control at that time, because they can talk and tell you what they need. So that is a good thing for someone who is in the process of dying.
Yeah.
Thank you. So Katie, yes, you're a social worker.
I am a social worker.
And you're a part of the team. There's a big team, but you two are here with me today.
Yeah.
So Katie, you're a social worker. What do you do? And how did you get to be a social worker working with palliative care of all the choices you could have out there?
Yeah. Social work is a very, very large discipline, right? It is. You can do any branch of humanity, right? You can dabble in. And that's one of the beautiful things about social work. You can go to opposite ends of the spectrum of life. But where I have always really centered was around healthcare and death and providing dignity for people within those parameters. And I think that for me, I started my whole career in social work started working with the homeless in Boston. And then it branched into doing a radiation oncology training and a little bit of experience there. And then I started working with individuals with young onset Alzheimer's and young onset Parkinson's. And that really opened my eyes to a lot of what people face living with chronic, serious, and debilitating conditions. And just the empowerment that we can give these patients and families to take control over their lives when so much feels out of control is really important. And it really gives people a sense of peace to feel like they're doing what makes sense for them. And I went to the World Parkinson's Congress a few years ago, and I saw a demonstration or a presentation from a palliative care provider and was talking about palliative, and it just rang everything that I was already thinking. It kind of encompassed into a discipline that made so much sense to me, and I didn't really know that it was such a well-established discipline. And so from there, I explored and I found a palliative social work position back in New Jersey, and I was there for about 5 years. And with palliative, we see the gambit, and with social work specifically, there's so much emotional turmoil that comes in general with, chronic illness, serious illness, the families involved. We always say we admit two people or two beings, right? We admit the family and the patient, right? When we start talking to people, and it's really just acknowledging that person's part of a larger system, and it's all, connected to each other. So we really try to, in social work, we try to honor the family, but we try to honor the emotions people experience, the anticipatory grief that's experienced through disease, through illness, is so important. Getting people to have conversations, right, that they wouldn't normally have, asking the right questions, the questions no one else is asking. Right, so that's what we do. And then, of course, with social work, we always do the resources. We always try to connect to the community, to ground within the community, to see what's out there, because no one's an island, and it's important to see what's out there. Yeah, so we do a lot.
As you guys are explaining what you do, I can see your heart towards people, towards being there for humankind. And people would ask me as a chaplain, how you do this, how you work with death and dying. And I always say, I don't know, I got here. Maybe it's my calling.
Yeah.
Maybe it's my calling.
Yeah.
But Katelyn, when you were talking and you're saying you went here and there and everything came into place for you, and you realized, this is where I belong.
Yeah.
Because you wanted to do that. And I say that's a calling. Not everybody can do this.
Yeah.
Now, because not everybody can do this, I want to ask Dr. Chowdhury, what are some of the difficulties you and your team face caring for patients and their families as you go, taking care of them?
I think often the difficulties that we face as we are a consulting team is that if a patient's prognosis from cancer is bad, the oncologist knows that there is nothing left to offer, but we are often the people to share that news or expected to share that news. So it becomes difficult when my colleagues don't feel comfortable having those difficult conversations, letting the patients know that this is the end, right? And as patients and families, they have built these relationships with their oncologist or with their primary care doctor or with their cardiologist or nephrologist, whatever the underlying condition is. And so for me to go in, or my team to go in and give them that devastating news or telling them that their time is up has been difficult. And a lot of times it's hard to go in and meet the patient families where they're at, because oftentimes I'm trying to have them meet me where I'm at. And that's where I think social work also comes in, for social workers to help our physicians be grounded and to remind us that they maybe don't have that medical background to understand why X, Y, and Z are no longer on the table. And so I think that is a challenge that I face on a daily basis. It's a challenge that I will continue to face in my career because every person is different. Everyone's hopes are different. Their wishes are different. And so it will be a challenge. And I think just kind of reminding myself why I'm here and to have that patience and be there and help the clinical team understand the difficulties that this patient is facing and their families facing, because they are not just a room number or a medical record number. This is a whole life. The other thing I often face is trying to figure out how much I take home with me, right? Because, automatically in the hospital, you only see the worst of the worst cases. And in your head, when you or your loved ones are going through it, those cases kind of jump back and you start thinking about, this is it. Well, I saw so-and-so in the hospital and this is exactly the symptoms they had. And so I think, again, reminding myself that in the hospital, we see the sickest of patients, and a lot of people are out there in the community living with chronic and terminal conditions who we don't see. So I'd say those are the two big challenges.
Yes. As you're talking, I can remember, just like, when someone says something to you and you have I had a nephew who passed away. I have a couple very close sister, my family members who passed, but one of them, the primary care doctor knew everything that was going on and couldn't say, you have 6 months to live or, however. And it's when he went to the hospital, the ED doctor said, look, man, you have, not knowing that he didn't know this. And as you said, the patient, the physician who is taking care of that patient, who have been with them all throughout, it's hard for them, some of them, to just say what's going on. And also, if they have to say it, how do they deliver it?
Right.
And so I hear that hurt, that downside, because you as a palliative care go in there and you have to give this news. And I'm saying, what if both of you went into the room or whomever, the palliative care and the physician? So at least there's a support, there's a face that they know already. And so we're still working on that, right?
Yep.
We're still working on that.
And to kind of pick up on that too, I think with palliative care, it's a specialty and it's a discipline, but it's also a movement, right? It's a movement to change the culture of how we give and receive healthcare and medicine. And it's going to take time, and it's going to take for our more well-established providers, right, out there in the world it's really a philosophy change. And change is hard and it's slow and it's painful. At the end of the day, though, we're moving in the direction that really gives individuals choice and knowledge to make their own decisions and empowering them to do so. So it's a fight worth fighting, but it is slow. And so sometimes it can be more difficult when you feel like you may be going, through the same thing over and over again, but it's always worth doing.
And bottom line is how you deliver bad news. And as a palliative care physician and social worker, and you have to go in there, and it seems as if I'm here to deliver bad news, but it's how you do it. Yeah. As you said, you meet the patients and their family where they are, because it's a family thing. It's not just the patient, and the patient is not just a patient. The patient is also a human being, and so you're thinking about yourself. How would you react if someone comes to you? I always say, if you can put yourself in that person's position, then you'll be better able to care for someone in that way. It's not just the disease, but the whole person. And so I am so thankful for what you guys do, and just hearing you, just talk about it. And I repeat it again. Your hearts. I can see and feel that in what you say. So many viewers may be wanting to specialize in this area. What advice would you give them? And I'm going to ask both of you individually to answer that question.
So I think the advice that I would give it is, it's not an easy job. And like you had said, it's a calling, because, the things that you hear and that you see on a daily basis are heavy. And to have that balance in personal and professional life is something truly to consider. Also, just knowing that not everybody you meet on this journey will have the same outlook or the same knowledge as you do, because knowledge is power. So to be patient, but if you feel like you want to make a change, or if you feel like you love talking, because we do that day in and day out, then palliative care is definitely something that you want to look into. And also just realizing that you don't have to be a social worker or a physician to do it. Palliative is a interdisciplinary approach. We have chaplains, we have social workers, we have nurse practitioners, physician assistants. We have a bunch of roles within it, because for a person to continue living and having a meaningful quality of life takes so many different disciplines. So I encourage everybody to really explore this specialty, to ask about it, to advocate for it if they have loved ones or family members, because oftentimes palliative medicine is just such a new field that a lot of people still are yet to know what we truly do.
Yeah, I agree with a lot of what Dr. Chowdhury said, and I think that if you're even interested, right, if one of your viewers is thinking, hey, maybe this is right for me, I would say it probably is, because people immediately know whether or not they can or can't do it, right? They say absolutely not, or that sounds interesting, right? It really it's polarized in that way in terms of what we can handle, right, and what we know of ourselves to handle. So I would say if it's something that you are interested in, it is worth exploring. It's worth doing. You don't even have to have a profession in it. There's so many good resources out there to learn more about it, about advanced care planning, about how to have conversations with families about, what you want for yourself. Start with your family. Start with your family to see, if these things were to happen, what would you want, and see how that conversation feels to you. If it empowers you and you feel like it was a worthwhile conversation, then maybe palliative is the right direction for you to be in. But if it is absolutely terrifying and it's not where you want to spend your day, right? Because we spend our day holding space for these conversations all day, then it might not be for you. But it's it's worth exploring. And then at the end of the day, it's taking care of yourself and knowing yourself, and being able to just take a step back and just appreciate the journey of it all.
When I started doing this, I started out as a marriage and family therapist, and I was doing my master's as a marriage and family therapist. And in the class, you have to say, which area would you like to specialize in? And I spoke with the professor, and he says, maybe hospice is for you. And so when we open up the class and everybody's saying, oh, where we want to specialize, and I said, I want to do hospice. I want to do death and dying. And they're like, what? It's like, you must be crazy.
Yeah.
And that is when you say, Katelyn, if you're right now saying something like that, like, what? No, that's not for you.
Exactly.
Or maybe later on, or maybe later on you will have an experience, oh Lord, where you say, well, you know what, I'm looking into this. Right. But
and that's okay.
Yeah,
it's okay.
It's okay. Either way. But people are called, I'm telling you, because you were, as you said, Katelyn, you were going here and there and trying to see where you fit in. Yeah. And then when you heard about palliative care, you said, oh yes, it clicked. It all come together. So maybe that's what's going on in your mind today. I'm so glad to have Dr. Chowdhury and Katelyn here on the red chair.
The red chair.
The red chair. And I thank you so much for being here. I know my viewers will appreciate this. And I want to say, this is not the last, right, of our talking together. Hopefully we'll get to chat some more
anytime
at another time. So thank you so much. I appreciate you for all that you do. Thank God for your ministry.
Thank you.
Thank you.